Hello everybody, welcome to Raaonline. I'm Dr. Abinaya. I'm your pediatric faculty for a Nelson-based pediatric teaching pediatric pulse program. So this topic under the chapter discussion on genetics, it is Down syndrome, and this is one of the, or this I would call it is the most salient lecture of all the topics in your genetics, and not only for exam purposes, this is going to be your lifelong reference. So I have taken references both from our Nelson textbook of pediatrics and the IAP's Down syndrome standard treatment guidelines. So you need not refer both of them. So all put together is present in this one particular lecture. So I'm sure all of you have seen children with Down syndrome and have treated, have evaluated Down syndrome. Some of you could have seen the karyotyping reports also. So most of the lecture would be, I think 50 to 60% of what I'm going to discuss now is something which is already familiar with all of you, and I'm just going to add a few points here and there. And very importantly, whenever we see a child with Down syndrome, the counseling of the parents is most important, and especially when they are planning for their next child, the recurrence risk has to be counseled. That information has to be given to the parents, and that is, I think, something which we don't usually do, and we straight away refer family to the geneticist. So that is something as a pediatrician we could definitely do, just based on the karyotyping or the fish report. Definitely we could do it, and we'll see how, right? So let's start with the introduction. It is the most common trisomy. We all know that the incidence is 1 in 600 to 1 in 800 live births. So it's such a common incidence. And I mean, even with such a common incidence, around half of them actually get miscarried in utero. And most of the babies who are born, they do survive. 90% of them actually survive. And 1/3 of the Down syndrome children do have a serious heart defect. So we need to evaluate with echo, and we will be seeing what are the surveillance methods that we have to do and during which time periods of the child's life. So let's move on to the history of Down syndrome. So this is a busy slide. I just wanted to showcase how far we have come in the management of Down syndrome. So way back in the 1860s, so probably if you're able to see here, it is around 1865, 1866. This is when Dr. Mendel, he gave his modes of genetic transmission, Mendelian inheritance. And I think around 1 year later, Dr. John Langdon Down. So Down syndrome is eponymously named after this doctor, Dr. John Langdon Down. So he also described these children who resembled each other, although they are not related to each other, but their facial features, their facial characteristics somehow resembled each other, and this was similar to the Mongols, the Mongolian people, the Chinese Mongolian people. So he had described these children, and after that, the similar characteristics was discovered by some other doctors, and some of them told that Down syndrome was associated with premature senility. And in 1903, Dr. Walter Sutton, he discovered that the problem lied in the chromosomes, and he identified that genes are present in these chromosomes. And later in 1940s, 1950s, it was identified Alzheimer's was associated with Downs. And finally, in the year 1959, a French physician, Dr. Jerome Lejeune. So he was a French physician. He identified that Down syndrome is a chromosomal condition where there is an extra chromosome. So instead of the 46 chromosomes, there is a 47 chromosome. So he identified that it was the trisomy. So probably around 100 years later, after Dr. Down identified these children, he came up with the trisomy thing. And then we had identified through karyotyping methods of what happens. And now we have latest techniques. I'm going to talk about the genetic testing methods in another video lecture of mine. So let's just stop here. I just want you to understand how we have traveled. So he is Dr. John Langdon Down. So he identified in 1866, and this is the French physician. So Dr. Lejeune. So he identified the 47 chromosome concept in Down syndrome. So these 2 or 3 slides I just have mentioned here just for the understanding sake, because this is the beginning of your genetic lecture. So, normally we have 22 pairs of autosomes and 2 sex chromosomes. So, 46XX or 46XY. Many variations can happen in the chromosomes. Either it could be in the structure or there can be a numerical variations. What we see here in the trisomies are, there is a numerical variation. So, either a trisomy 21, trisomy 18, trisomy 13, all this, then extra chromosome is added. This is a numerical variation. But we have a lot of structural variations. We know about insertions, deletions, isochromosomes, ring chromosomes. All these are structural variations. In structural variations, what happens? The structure is different, but the chromosome number is going to be the same. It is going to be 46XX or 46XY, but because of the rearrangement, some gene has been deleted, say a Williams syndrome where a particular gene alone is deleted. There can be a duplication, there can be an inversion, translocation, insertion, ring chromosome, isochromosome, all these are structural rearrangements. Here the number of chromosomes will be the same. See, this is not about Down syndrome, I am just explaining in general, right? So, I just want you to pay attention to these 2 slides here. So, in the structural chromosome changes, so first what happens in a deletion? See here, it is labeled for easier understanding A, B, C, D, F, G, H, right? Here there is a deletion of this gene labeled as D. So, the resultant chromosome will not have this D gene alone. So, it is A, B, C, E, F, G, H. So, here a deletion had happened. Next is a duplication. Duplication means just copying of the same thing. So, here A, B, C, this B and C, these 2 genes have duplicated. So, the resultant chromosome will have A, B, C. Again, there is a B, C. So, this is duplication. Inversion. So, this particular segment gets inverted. Here it is A, B, C, D. What happens in the resultant chromosomal segment will have inversion. So, it is A, D, C, B. This is inversion. What about translocation? Translocation is between the between that one pair of chromosomes. So, there are 2 chromosomes over here. Particular segment, gene segment can move from one chromosome to another. If it is a balanced translocation, that is what we refer to as a Robertsonian translocation. Okay, so there is a balanced, the genes that gets transferred from one chromosome to the other, it is very balanced. It's well balanced. Okay. So, here the translocation happens. Here the AB genes have moved on to the shorter chromosome here. So, the M and O comes to the longer chromosome and AB has moved to the shorter chromosome. So, this is a translocation. This is a reciprocal translocation, and if it is very uniform and equal, then it is called as a Robertsonian translocation. So, what is a isochromosome? Isochromosome is the resultant chromosome. What happens? Instead of longitudinal cut, there is a transverse cut. And when there is a transverse cut, what happens is the resultant chromosome is very equal. It has not just short arm, long arm, but both are short arms or both are long arms. Here you can see that both are short arms, here both are long arms. So, this is a transverse cut that happens in a chromosome that results in isochromosomes. What happens in a deletion? Deletion is simply some part of the chromosome is lost. It can be a single gene, it can be a group of genes, etc. Inversions we just dealt, and ring chromosomes. Ring chromosomes, again, when there is a cut in these chromosomes, what happens? These blunt ends, okay, so those 2 blunt ends will come together and they form a ring like thing. So, this is a ring chromosome. The cut products will be lost. Okay, so these are the fragments that get lost. And what about duplications we just saw? So, it gets duplicated, BC getting into again one more BC in the previous slide. Translocation, I just told you that if it is a balanced translocation, that is called as a Robertsonian translocation. What happens in Down syndrome? Down syndrome, we know there is a trisomy in 21 chromosome, right? But not all the children with Down syndrome do have pure trisomy, only 95%. Okay, of course, this is a majority. 95% have this pure trisomy. They have trisomy of 21. Why there is a trisomy of 21? Pure trisomy is when there is a cell division, especially in the meiotic division number 1. So, meiosis occurs twice. In the first meiosis, if there is a non-disjunction of these cells, of the chromosomes, okay, so inside the cells, these are the chromosomes. What happens? The chromosome 21 divides, and this cell is supposed to receive only 2 sets of chromosomes, but because of the non-disjunction, what happens here? This cell gets 3 chromosomes and this cell contains only 1. So, this is a monosomy. This becomes a trisomic cell. And when this trisomic cell combines with the sperm, the resultant will be a trisomy 21 child. So, this is what you have to pay attention here is the cell division is number 1, that is meiosis 1. Okay, so when there is a non-disjunction, and where should the non-disjunction? It should occur in the maternal cells. Okay, so it is the pure trisomy 21 is 95% of the children do have pure trisomy 25%, and the insult or the problem occurs when there is a maternal non-disjunction at meiosis number 1. Okay, so this you have to write. This is something compulsory that you have to know. What happens here? So, same thing has been explained here. So, these are the egg has an extra chromosome. So, egg is fertilized with a typical sperm. So, all these cells will become trisomy, trisomy, trisomy. So, this is the most common thing. Next comes the translocation. So, 95% is pure trisomy. That is because of the maternal non-disjunction of at meiosis 1. So, remaining 4%. Okay, that is because of a translocation, and translocation most often it happens between 14 and 21 or 21 and 21. So, here the translocation is basically, there is a translocation from some parts of the chromosome of 21 gets translocated into 14. So, here the numerical value is the same. Resultant, it will be only 46 chromosomes. When you do a karyotyping, when you count 46XX or 46XY. So, the resultant number will be the same, but the structure when you see that here you can see small extra segment of the chromosome in 14, right? Can you see here? So, this has been taken up from 21st chromosome. So, there is either a partial copy or a full copy can be there. And whenever there is a translocation, always get a parent's report also. So, this is the Robertsonian translocation. So, this was identified by W.R.B. Robertson in the year 1916. He identified it in grasshoppers very interestingly. So, what happens here is the translocation happens if it is a uniform, involves 2 acrocentric chromosomes. What we get is a very, very balanced translocation, that is called as an Robertsonian translocation. So, happens between 2 acrocentric chromosomes, and what we get is a balanced chromosome, that is called as a Robertsonian translocation. So, this can be homologous or non-homologous. So, the translocation can happen between acrocentric. So, one is 14, 21. So, from this 21 here we get some extra chromosomal segments here, and there is a translocation 21, 21. So, these are all this is about the translocation. So, translocation happening between 2 acrocentric chromosomes is what you have to write. And it can happen between 14 and 21 or 21 and 21. So, that was 4% of the Down syndrome cases. The remaining 1%, very, very uncommon, least common of all is mosaicism. So, mosaicism means in a particular individual, there are cells which have trisomy, there are cells which have normal 46XX or 46XY. Okay. So, that is the variability. And mosaics are usually, because they have 2 types of cells, the normal cells and the abnormal cells, mosaics are usually less severe, and even their phenotype is not the typical Down's phenotype. But it is very uncommon, only 1%. And based on this, why we are concerned about does the child have trisomy, does the child have translocation? So, why are we concerned about it is to predict the recurrence risk. Of course, the family will want another child, isn't it? So, we need to counsel. So, first get the child's karyotyping. If it's a translocation, get the parents' karyotyping, because we need to see from which parent the translocation was inherited and what translocation was it, either 14-21 or 21-21. Say if it is the most common, say the child has only pure trisomy 21, all the cells have trisomy 21. And if it is the first child and they want to beget another child, the recurrence risk is less than 1%, because that has happened, in that fetus in utero, when the cells were dividing, there was a maternal non-disjunction at meiosis 1. So, it happened in that particular pregnancy only. So, the recurrence risk of such a mother getting another child with Down syndrome is actually less, very less than 1%. Okay. In case they have 2 children, both children with trisomy 21, then the risk can increase to up to 10%. Say this is about trisomy 21. One child only, they want to get another child, then you have to counsel that, see, recurrence risk is only less than 1%. This pregnancy only the trisomy thing had happened. If they have already 2 children, then you have to warn them that, okay, next child there is a 10% risk. Okay, this is about trisomy. Got it? Next is the translocation. So you have to identify if it is a 1421 or a 2121 translocation, and where is the translocation, if it is inherited from the father or if it is inherited from the mother. If mostly when we are talking about this translocation, if it is from the father, usually the recurrence risk is less when compared to the mother. Okay. So if the father is a carrier of 1421 translocation, the recurrence risk is less than 2%. Okay. If the mother is a carrier, then recurrence risk rises to 10 to 15%. Roughly you can remember 10%. Father means it is less than 2%. Say if it is a translocation of 2122. Okay. So that is also possible. And if it is from the father, it is 5%, and if it is from the mother, it is 10%. Say if it is a translocation of 2121, then 100% there is a recurrence is that next child also will have it, because 21 there is already trisomy. So next child also is going to be born with Down syndrome. So this is one particular translocation where the recurrence risk is 100%. Okay. What about the, okay, this is a child, a male child, there is a female child, both of them affected with Down syndrome, and if the male child becomes an adult, will he be fertile? No. Usually Down syndrome males are sterile. But what about the female with Down syndrome? They can beget children, right? So a mother with trisomy 21, so a Down syndrome female, if she becomes pregnant, there is a 50% risk, because she carries half of the genotype of the unborn fetus, isn't it? So 50% there is a risk that this Down syndrome female begetting a child with Down syndrome. So this is about the recurrence risk. So shall I go on like once again? Okay. So we have to see first what type of karyotyping the child has. Okay. So if it is a trisomy, or is it a translocation, or is it a mosaic? Mosaics have the least recurrence risk, less than 1%. Okay. So leave that. So next is karyotyping you have done. You got a trisomy 21. Of course, 95% of the children do have pure trisomy 21. If it is a first child, then you have to advise that the next child recurrence risk is less than 1%. If there are 2 children, the trisomy 21, the third child can get up to 10%, there is a risk. So this is about trisomy. The confusion arises when there is a translocation. What kind of translocation? Usually the translocation occurs between the acrocentric chromosomes 1421, 2121 or 2122 translocation. So 3 different types of translocations can happen. 1421 translocation, if it is a father, it is 2%. If it is a mother, it is 10%. 2122 translocation, if it is father, it is 5%. Mother, it is 10%. Okay, remember this. If it is a 2121 translocation, 100% the child is going to be a trisomy 21. 100% risk of Down syndrome. If the father, or if the a male child with Down syndrome becoming an adult, usually sterile. No, you cannot predict the recurrence risk. Okay, it is sterile. Child becoming an adult, and she is asking what is my chances of begetting a child with Down syndrome? It is 50%, because she will share 50% of the genotype of the child, of the baby, or on the unborn fetus. Okay. So I think I have not confused you enough. Please go through this. This is quite simple only, but this is what we have to tell our parents. Yeah, so this is the same thing what was I telling you, and I'm not going to tell this again. Okay. So very importantly, nowadays we do diagnose Down syndrome in the prenatal period. So with some subtle markers, I'll tell you. I think I have. So these are some of the, before even going for CVS or amniocentesis, some subtle markers on ultrasound will tell us, or will give us a clue that it could be trisomy, and then we go for the screening, right? So there are many soft markers which are identified on ultrasound because of thanks to the advances in ultrasound nowadays. So we see many reports. Antenatally also, parents, the expectant parents do come to pediatricians asking, should we keep the child or not? Should we abort? So many times we need to counsel the parents. So you would have seen that in the antenatal ultrasound, there is an echogenic bowel, there is an echogenic focus in the heart, there is a hypoplastic nasal bone, the nuchal fold thickness is so and so, the Unossified nasal bone is something that's very common. There's an aberrant right subclavian artery, ventriculomegaly, etc. So, choroid plexus cyst, all these things are there. These are very, very soft markers, but strong markers, I would say these 4. Completely absent nasal bone or unossified nasal bone, increased nuchal translucency, presence of URSA or ventriculomegaly. So, these 3 to 4 are the strong markers, and definitely, so depending on which duration or which point of pregnancy the expectant mother is, so we should suggest her either a CVS or an amniocentesis. Yeah. So, CVS is usually, CVS chorionic villus sampling is usually done in the, preferably before the second trimester, that is between 11 to 13 weeks. Okay. Amniocentesis is usually done in 16 to 18 weeks. So, CVS, usually at this time, we would be able to see the chromosomes, the number of chromosomes, the numerical abnormalities we will be able to see, and not exactly the structure, but amniocentesis can give us the structural abnormalities, right? So, this is the difference between chorionic villus sampling and amniocentesis. So, we have to identify, like during the NT scan, which is done at 11th or 9th to 11th or 9th to 12th week, mostly the NT scan should have been completed. So, based on the nuchal translucency scan, based on the mother's age and certain tests that we do, the triple test, the quadruple test, etc. So, based on the maternal biochemistry and the fetal USG findings, we should start our counseling process. And why maternal age is important? We are all very familiar with this concept that as the age progresses, as the maternal age advances, the incidence of Down syndrome becomes more common. For example, under 30, it is only 1 in 1000, less than 1 in 1000. See, at 40, it is 1 in 105. At 50 years, it's 1 in 12. So, as the maternal age advances, the incidence of Down syndrome increases.